Hello, our first presentation will be by Dr. Ruth Schneider. She is an Assistant Professor of Neurology at the University of Rochester, and she specializes in movement disorders. She has clinical and research experience with the implementation of telehealth prior to the COVID pandemic and the utilization changes that occurred during the pandemic. In addition, she's published on the use of digital technologies to provide objective assessments of individuals outside of the clinic environment. She will bring this expertise to her presentation on telehealth in clinical use.
Hi, my name is Ruth Schneider, and I'm an Assistant Professor of Neurology at the University of Rochester. In the US, COVID-19 was declared a national emergency on March 13, 2020. The use of telehealth visits, which here I use to refer to real-time video-based visits between a provider and a patient, increased quite quickly. By the last week of that same month, telehealth visits had increased by 150% compared to the same week in 2019. A look at primary care visits for Medicare recipients revealed that over 40% of visits were conducted by telehealth in April of 2020 alone. And another study examining primary care and specialist visits for both those insured by Medicare and those with commercial insurance found that 30% of all visits were conducted by telehealth between mid-March and mid-June of 2020. Now, clearly, the primary impetus for this increase was the pandemic and the desire to decrease COVID-19 exposure. However, there are many other advantages to telehealth. Visits can be conducted in the patient's home, whether it be a community dwelling, a nursing home, or an assisted living facility, or even an office or other preferred environment. Visits are convenient, saving patients both time and travel. Visits provide the unique opportunity for new insight into the patient's life, offering the potential to enhance the provider-patient relationship and improve care. Visits can also be complemented by remote monitoring, whether it be heart monitoring, remote glucose monitoring, or remote assessment of daily functioning. On the other hand, there are also some readily apparent disadvantages. Some tests simply cannot be performed. Others require modifications or even in-person assistance. And both the quality of the internet connection and the environment matter. A poor connection, a poorly lit environment, or a poorly positioned camera that limits the view of the patient can greatly hinder the visit. Nonetheless, the value of telehealth visits as an adjunct to in-person care is clear, and telehealth is here to stay. I don't want to ask my patients with advanced disease who live far away to travel hours to spend 30 minutes in the office with me. I don't want to give up the ability to see my patients who winter down south. I don't want to ask my patients to take hours off of work to travel to the clinic. And I think my patients would agree. The COVID-19 pandemic has disproportionately impacted Black and Brown communities. Disparities in access to telehealth threaten to exacerbate existing inequalities. One study examined successfully completed telehealth primary care and specialty visits at a large academic center and found that older adults, Black patients, Latino patients, and those with lower household income were less likely to complete video-based visits. In another study, fewer visits with older adults, non-white patients, patients with a non-English preference, or government insurance were completed after the switch from in-person visits to telehealth visits. We need to be proactive to prevent widening of existing health disparities. So how do we ensure equitable access to telehealth? Here are my thoughts. Number one, reduced regulatory barriers. During the pandemic, temporary changes removed limitations on where and with whom visits could be conducted and eased licensing restrictions. We need to ensure that the temporary changes put into place to facilitate telehealth during the pandemic are made permanent. Two, ensure payment parity. Telehealth visits should be reimbursed at the same rate as in-person visits across the board by all insurers. Three, partner with community organizations. We must work with trusted community organizations to provide education, provide needed supports to facilitate the use of telehealth, and collaboratively develop the best models for telehealth. And four, it is critical that we provide high-speed broadband internet for all. Thank you very much.
Hello, our next presentation will be by Dr. Jay Alberts. He is the director of the Cleveland Clinic Concussion Center and the vice chair of innovations of the Neurological Institute. He has coordinated large multidisciplinary teams in the development of a variety of methods of technology-enabled data collection and has experience with the development and integration of multiple digital assessment tools for both research and clinical use. He will present today on the use case of digital neurologic assessments to stimulate discussion regarding remote monitoring of patients.
My name is Jay Alberts, and I am the Vice Chair of Innovations of the Neurological Institute at the Cleveland Clinic. I appreciate the opportunity to participate in this unmeeting meeting today, where I'll talk a little bit about technology-enabled neurological care, and in particular, our digital neurological vital signs application that we've been using. So certainly COVID-19 has catalyzed all of our efforts to get into the telemedicine space and think about interesting and novel ways that we can connect with our patients in a remote manner, just to keep them safe as well as to minimize disease spread. Now, I would argue that these are great efforts, but in many ways, what's old is new. And so in 1962, the Jetsons, who may be considered telemedicine pioneers, were already doing a lot of what we're going to be talking about or have been talked about today. So there we have Leroy getting a evaluation with really looks like a FaceTime visit to me. And then we have George going to swallow a pill with a camera. Now it's taken us a pandemic to get to where the Jetsons were, but that's okay. Sometimes we need some sort of push. So what we've been looking at from a digital neurological vital signs is really trying to quantify meaningful neurological function. And if you look in the literature, any four of these, there's a whole stack of papers indicating that they should be the sixth vital sign: cognition, upper extremity function, walking speed, and health literacy. Cognitive function clearly important for neurological populations, but also healthy older adults as they may transition. Upper extremity function is a clear indicator of who is going to end up in a dependent care setting. Walking speed is an indicator of fall risk or fall rates. And health literacy is a good marker of patient interaction, how well you can be engaged with them and they can engage, as well as medication compliance. So one of the things that we feel are important in terms of developing the applications or solutions to enable telemedicine are to have certainly remote collection, clearly. They also need to be self-administered. What we don't want to have happen is the patient doing these tasks in front of, for the most part, the clinician. Rather, we'd like to have them self-administered before they have their virtual visit scheduled. So those data can then be integrated into the electronic health record, and the patient and provider can actually see their performance. Now, what's important about this is also providing objective and quantitative data, not simply delivering questionnaires via FaceTime. So if you see in the bottom right there, we have an example of the TUG. This is a timed up and go. It's a standard clinical assessment that's used. And what you see is here, each smartphone or tablet has accelerometers and a gyroscope. And what we can do is actually more precisely measure their performance than if we were seeing them in person. So we can see how their walking speed is. And importantly, we can see their turning or evaluate their turning. And this is important because most people don't fall as they're just walking in a straight line. Rather, they fall when they're turning or when they're transitioning, doing a turn to sit. So now we can evaluate that in a very objective, quantitative manner. And these are the types of tests that we're also using in the clinic during in-person visits. So again, this allows the virtual visit or the telemedicine visit to be connected to their experience in clinic. And with this same type of data being used in both situations, a patient can be evaluated inpatient or in clinic. 6 months later, can do the same test at home. And so the provider and the patient can then see how are things changing. Are they getting better or getting worse? So this is where we are. We certainly have a lot of issues to be solved. Accessibility to technology is important. So there is some recent data suggesting that rural and underserved populations are actually more likely to have a smartphone and less likely to have a PC or a laptop. So certainly there is this push for the appification or justification to put many of these applications on a smartphone or even a tablet. Have to make sure we're collecting meaningful outcomes that actually inform care. just because we can collect data doesn't mean that we should do it. We need to be collecting meaningful outcomes that are going to help the provider provide better information and engage the patient as well in terms of understanding where they are in their functioning. Certainly payer considerations, regulations, and practice of medicine across state line, something that needs to be addressed. And finally, I want to talk about the focus on service and not technology. So I'm a technology guy. I develop technology, and I think a critical aspect is that we can't let the technology drive this process here. We have to be driving the process and using technology to enable better care. And that's really been our theme here, is using technology to drive better care and to drive better outcomes and better understanding of the patient. Thank you very much.
Hello, our next presentation is by Emily Yoder. She is an analyst at the Centers for Medicare and Medicaid Services. She will bring her experience at CMS to discuss payment structure of virtual versus in-person care and the changes that occurred during the COVID-19 pandemic. This will help frame the discussions regarding payer and policy roles and access to telehealth care.
Hello, everyone. My name is Emily Yoder, and today I'll be sharing 4 slides describing Medicare payment for Medicare telehealth and for other services furnished using communication technology. Just some quick background. Medicare telehealth services are reimbursed off the physician fee schedule, which is a $90 billion payment system, and these are payments for professional services furnished to Medicare beneficiaries. Payments must be resource-based, and they take into account physician or other practitioner work, practice expense, which are the things sort of associated with running a practice, things like office supplies, clinical staff, equipment, etc., and malpractice insurance. Payment is made at the code level, with each code generally describing a discrete service. The physician fee schedule is updated annually through notice and comment rulemaking, and this includes any changes that are made to payment policy for Medicare telehealth. So for purposes of physician payment policy, we tend to divide the world of virtual services into Medicare telehealth and non-Medicare telehealth services. So to start with Medicare telehealth, Section 1834M of the Social Security Act specifies the circumstances under which Medicare makes payment for services that would otherwise occur in person, but are instead furnished using telecommunications technology. These services, which are described using the same codes as what they would have been if they were done not as telehealth, are subject to restrictions on geography, site of service, practitioner type, and technology. Generally speaking, beneficiaries must be in rural areas and also in medical facilities, so not in their home, in order to receive a telehealth service. Additionally, the technology must be live two-way audio-video communications technology, with the exception of federal telemedicine demonstration projects in Alaska and Hawaii that can use asynchronous or store and forward communication technology to furnish those services. When all of these restrictions are met, the services are paid using the in-person payment rate. Now, for other virtual services, CMS actually has long-standing policy of paying separately for services that could use communication technology as part of the provision of the service, but that we do not consider to be subject to the restrictions in 1834M. For example, we pay separately for remote interpretation of diagnostic tests, care management services, and even the global surgical packages all could use some kind of communication technology as part of the provision of the service. We also pay for a discrete group of services that we call communication technology-based services, which are generally short services furnished using communication technology meant to prevent the provision of an in-person service. And these reimburse at a much lower rate than telehealth. COVID-19 has really changed the telemedicine landscape. Through statutory waivers and emergency rulemaking, we were able to expand access to virtual care, with the most significant changes in the world of Medicare telehealth. While some flexibilities, such as the relaxation of the geographic and site of service restrictions, require Congress in order to maintain, Others, such as the range of services that can be provided through Medicare telehealth, fall under CMS's regulatory authority. This final slide describes the approach CMS took in the CY 2021 PFS rule to make some of the services available during the PHE permanent and to allow others to be provided as telehealth temporarily after the conclusion of the PHE. We very much look forward to collaborating with the stakeholder community as we work to determine which of this expanded range of services are appropriate for telehealth going forward. Thank you.
Our next presentation is by Dr. Lisa Levine. She's the Chief Executive Officer of the Maven Project, which is a telehealth nonprofit that supports primary care providers in delivering comprehensive care to vulnerable patients in underserved communities with volunteer physicians via telehealth. She will discuss her experience at the Maven Project to highlight the potential and the barriers to use of telehealth in underserved areas.
Greetings from the Maven Project, Medical Alumni Volunteer Expert Network. The Maven Project is a 501c3 nonprofit organization founded by Dr. Laurie Green, who's a practicing OBGYN in California and former president of the Harvard Medical School Alumni Association. We pair expert volunteer physicians across 51 specialties, ranging from primary care to specialty care disciplines, adult and pediatric medicine, and surgical and behavioral health subspecialties, with primary care providers caring for America's vulnerable patients seeking care in local community health centers via telehealth. We communicate and partner with rural communities and urban medical deserts across 13 states and expanding. As community need skyrockets, which is magnified by the COVID impact, our community health center partners are increasingly understaffed, under-resourced, and the providers that are serving vulnerable communities are isolated as the clinic structure is atomized. Telehealth and the underserved. Telehealth really provides availability, access, and answers. It can right-size where and how care and connection and vital information is accessed. It doesn't require additional information and can be leveraged via phone, computer, or tablet. Telehealth really can support and empower local providers caring for the vulnerable or the underserved to have answers and resources wherever and whenever they need it. This can stabilize the shrinking yet vital provider workforce in local communities and enables local providers to confidently support, advocate, educate, and care for at-risk communities in a culturally competent manner, whether it's related to COVID or any other condition. This can decrease barriers to accessing really needed care by answering and managing care and questions for the community. The Maven Project approach is a virtual provider-to-provider approach with a relationship-driven strategy, partnering with local community clinicians. We provide medical consults and advice, whether it's e-consults, so email consults, video consults, or on the phone, audio only, one-on-one mentoring, whether it's with frontline primary care providers or with the leadership of the clinics that we partner with. And we provide educational sessions, which are live didactics, including a weekly COVID update and topics ranging from chronic care management to any other topic. And we have CME credits associated with many of our sessions. Our virtual multi-specialty group practice really empowers local clinicians to provide comprehensive, culturally competent care via really personal and professional support, helping to craft care plans within the resources available to the patients. We have been referred to as an angel on their shoulders. Our services are delivered effectively free of charge to clinics with a minimal maintenance fee for those who are able to pay. This enables care to be right-sized, optimized, and avoids care delays, stress, and cost. Some of the recent impact data from our medical consults includes 82% of the time referrals are saved for the patient based on the medical consult. So these are consults that ordinarily would have sent a patient out of the clinic. We are able to keep care local and optimize it for the patient. 97% of the time, our consults provide education, which can apply to future patients. And the average provider experience with our physician volunteers is amazing, 4.9 out of 5. We had the good fortune of a recent pro bono consulting engagement with McKinsey & Company, who quantified some of our impact, which we call the multiplier effect, which conservatively states that one encounter with a Maven Project expert provides knowledge that can be applied to up to 19 patients that year. This is really increasing sustainable local knowledge capacity and improving quality, decreasing cost, stress, and burden. And our job is not done until our services are accessed by every community that needs us around the country. Thank you.
Hello, our next presentation will be by Dr. Julie Risch. She's an assistant professor of medicine at the Cleveland Clinic College of Medicine and the director of design and best practice in the Office of Patient Experience at the Cleveland Clinic. She has experience partnering with patients to transform healthcare, identifying best practices for patient experience, and developing innovative strategies to improve healthcare. She will provide context on our current understanding of patient-perceived barriers to telehealth to stimulate discussion on how to better identify and overcome these limitations.
Thank you so much for the opportunity to share. Understanding what patients and potential patients want is the problem to solve to truly transform care and embrace a digital era. For organizations like ours who are serious about their customers, they employ human-centered design to develop programs and technology based on what actually matters to people. Human-centered design is a process of deep empathizing, ideating, designing, prototyping, and testing with your key stakeholders, both patients and caregivers, by your side along the way. This ensures that the needs, the motivations, the core values, and importantly, the behaviors of those people will be heard and included. Technology has been and will be significantly embedded in healthcare. Just look at the advances made in virtual health, both planned and unplanned in the past year. We're also seeing numerous on-demand virtual healthcare companies coming into the market and lots invested in these types of ventures. Technology has allowed us to solve for some of the known challenges and pain points, like the ability to schedule online, how virtual health extends care to your home, to your community, to your schools. Yet, it is not a panacea for all healthcare challenges. Our research revealed that there are large segments of those who receive care who question the perceived value of virtual visits, cannot overcome the access challenges, or feel unable to learn what they think is a complicated technique, and suffer fatigue and frustration with online questionnaires. Patients have varying access to and preferences for technology. We often think of this as not having access to the right device or internet, and certainly that's something we hear. Patients also interpret this as access to the life they want to live and struggle because they don't have the tools to optimally care for themselves. For example, Naomi is trying to manage her COPD while caring for a very sick husband. She doesn't feel she's able to quickly reach her care team when she is in need. And so she allows herself to wait the exacerbation out. What she really needs is to understand what's happening, what's causing it, and what does she need to do right now. For Naomi and many others, technology provides an opportunity to extend care to meet that core need and answer the question of what do I do? Although technology can be an adaptable enhancement to care delivery, it cannot be a requirement to the success of a healthcare initiative. Patients have unique needs, and we must meet them where they are in the mode they prefer. Let's look at Anthony, a 42-year-old who was recently diagnosed with heart failure. He wears a smartwatch. He tracks his heart rate. What he doesn't know is how to process that information in a way that can buy him more freedom. Instead, he's scared to death to get up from his chair and walk to the kitchen. Interestingly, patients question the value of technology and if it can be a proxy to in-person visits. Feeling heard, seen, and physically examined, as well as having the ability to read the provider's reaction, are essential to finding value in the visit. Take Trevor, a 68-year-old with heart failure who questions the financial value of virtual health. He says to me, they can actually touch me, take my blood pressure instead of me taking it and telling them. I want them to do that instead of me doing it and telling them. I'm paying for the doctor. I want to be in front of them. We are putting forth efforts, but they are often episodic, oriented towards single solutions, like enabling a virtual visit or self-scheduling, undoubtedly impactful and very successful for that specific thing. We are creating solutions for aspects of patients' health, and they're seeking solutions for the entire life. This is complicated, confusing, and disconnected. What if we shifted to partner in a way that we do what they know best themselves into the way we delivered care? to provide a menu of options based on the unique experiences of each patient. What if we helped you move from researching your symptom to finding the right provider to coordinating your appointment, understanding your illness, and we did this throughout your life? Imagine what it would be like to have a partner that could guide you when, how, and where you wanted. To change the healthcare experience and leverage technology optimally within that change, we must have interconnected solutions that achieve what matters most to our patients. Thank you so much for the opportunity to share.
Our next presentation is by Dr. Kathy Wright. She is an assistant professor at The Ohio State University College of Nursing, and she has led biopsychosocial studies evaluating the role of racial and ethnic disparities in brain and blood pressure health in African Americans across the lifespan. She also has experience with telehealth through community health education for urban aging residents. Her presentation will be the basis of the discussion regarding the unique challenges utilizing telehealth for minority populations.
Hello, my name is Kathy Wright, and I'm an assistant professor at The Ohio State University College of Nursing. And I want to introduce to you Ms. Pamela Shields, who is the director of the Urban Aging Residents Coalition, and she will be joining us for our discussion regarding connecting urban and aging residents through telehealth. So we know that we want to provide good quality care to our aging residents. And a way that we can do that is through embracing the triple aim in the use of health information technology. So we want to be able to improve population health as a whole, lower cost, and more importantly, we want to improve the quality and the patient care experience for older adults in telehealth. We know that disparities do exist when it comes to telehealth. In a recent Pew poll study, looking at even the use of technology among African Americans, older African Americans, as well as those who have not attended college, are significantly less likely to go online or to have broadband service at home compared to whites with a similar demographic profile. 92% of African Americans own a cell phone and 56% own a smartphone. So there is opportunity to reach people with health information and using health technology. And in a study of cancer patients, the health disparities exist in relation to use of telehealth visits, with whites having more access and use of telehealth visits than any other population. As we begin to think about what can we do to bridge that gap, we also need to consider various frameworks that we might want to use in order to explain how we can better improve telehealth. I like this particular framework from Singh and Satig because it focuses on health and safety in a telehealth environment. In particular, providing integrity, accountability, and confidentiality. So this is how we are bridging the gap, just one project at a time. The Urban Aging Residents Coalition that was developed by Ms. Pamela Shields actually invited me to join them and provide mindfulness-based education and training on how to prepare for doctor's visits. And we've actually used an infographic from Dr. Knighton, who is one of the KL2 scholars. So what our charge is to educate, collaborate, and disseminate. Thank you.
Our final presentation of this morning is by Dr. Laurie Urscher Pines. She is a senior policy researcher and the research quality assurance manager at the RAND Corporation. She has research interests in telehealth, maternal and child health, telehealth programs in safety net settings, mixed methods research, and emergency preparedness. Her presentation today will discuss telehealth in chronic conditions, and she'll specifically discuss an example using her recent research with substance use disorder treatment model.
Hello, everyone. In this quick talk, I'm going to provide a brief overview of telehealth for the treatment of opioid use disorder and how its use has changed since the COVID-19 pandemic started in March 2020. So first of all, although 3 million Americans live with an opioid use disorder, only about 1 in 5 actually receive medication for OUD, or MOUD, as I will call it in this talk. There are numerous reasons why patients have trouble accessing care. However, one key reason is that many communities lack clinicians who can prescribe buprenorphine and other medications used in the treatment of opioid use disorder. In the past few years, policymakers had recognized the potential of telehealth to improve access, and use was growing for this population with opioid use disorder. However, it took the COVID-19 pandemic to really catapult telehealth into the mainstream for the treatment of OUD. With COVID-19 came a slew of policy changes that allowed clinicians a lot of flexibilities to use telehealth virtually overnight. As a result, practice patterns quickly changed. First, telehealth visits grew from less than 1% of all OUD outpatient visits prior to the pandemic to approximately 1 in 4 visits in May 2020. Clinicians also reduced the frequency of urine toxicology screening or stopped doing it entirely so patients could avoid a trip to the clinic. Interestingly, the transition to telehealth has had different impacts on different populations of patients. Our analyses using commercial claims showed that although established patients continued to have visits and get prescriptions during the early pandemic, the same was not true of new patients. In fact, the number of new patients receiving first-time prescriptions in the spring of 2020 decreased by over 30%. So now I'd like to talk a little bit about the advantages and disadvantages of the telehealth delivery model in which you serve patients with OUD in their homes. First, during a public health emergency, this model really does support social distancing and helps to conserve personal protective equipment. However, even in routine times, it can increase convenience for patients, for example, with work or caregiving responsibilities. Third, telehealth really can increase access in communities without waivered providers, for example, certain rural areas. And it can also provide additional privacy and address some of the stigma associated with seeking in-person care. For example, a patient doesn't need to be seen with their car parked outside of a local treatment facility. And then finally, clinicians have told us that this model can really provide insight into a patient's home life. And the fact that you are seeing patients in their homes can improve the therapeutic alliance and help build rapport. However, there are also some drawbacks. First of all, frequent in-person clinic visits, as is common with traditional OUD treatment, really provides a structure that supports accountability, and that can be difficult to replicate in a virtual setting. Second, the home environment, as we all know, can be chaotic, and telemedicine visits can be interrupted. There can actually be privacy concerns here too, when sensitive conversations can be overheard by household members. In addition, telehealth visits tend to be shorter and more transactional, but technical problems, for example, establishing an internet connection, can add time. Perhaps most importantly, however, is that clinicians report that with video or phone especially, there's less information to inform clinical decision-making because you can't lay hands on the patient. Another issue too that's important to point out is that the mode itself can be rather cold and impersonal. So some clinicians have told us that although being in the home setting can help with establishing rapport, there can be drawbacks here as well. And then finally, telehealth may not be appropriate for all patients. For example, patients that lack devices or patients without broadband or patients with limited digital literacy. So in summary, telehealth for opioid use disorder has some important bright spots and some downsides. And policy and clinical practice going forward will have to figure out how best to leverage telehealth strengths to improve access and quality. I look forward to discussing these topics at our upcoming meeting.